Good morning, good afternoon or good evening, wherever you are joining us from around the world in this ISQua Fellowship Program webinar. I am Peter Carter, the Chief Executive Officer of ISQua, and we have as our special guest today delivering this webinar, Dr. Rashad Massoud. Dr. Massoud is a physician and public health specialist internationally recognized for his leadership in global healthcare improvement. He is the director of the USAID Healthcare Improvement Project and the newly awarded USAID Applying Science to Strengthen and Improve Systems project. He is a senior vice president of the Quality and Performance Institute at the Institute of University Research, leading URC's quality improvement efforts in over 30 countries. Dr. Rashad Massoud is speaking today on scaling up high-impact interventions. He's led several scale-up efforts, and he's regarded as one of the foremost experts on spread and scale-up. Rashad Massoud is also a good friend of ISQua, having led the USAID's collaboration with ISQua in a 17-country African meeting in Ghana in February this year. So it's both my professional and personal privilege to introduce Dr. Rashad Massoud to this webinar, and I'll now ask him if he would deliver it for us.
Thank you very much, Peter. It's a pleasure to be with you and to be talking about a topic that I'm very passionate about. The first thing I want to do is just take us through a quick definition of what we mean by spread or scale-up. And just as a side remark, some people may differentiate between the two words. Myself and several of my colleagues, we do not. We use spread or scale-up interchangeably. And for the purposes of this particular webinar, I'm going to be using both of them in that way. Interchangeably, they mean one and the same thing. One of the definitions I like most about what we mean by spread or scale-up comes from a colleague and a friend, Joe McCannon, who several years ago sort of framed it as it's the science of taking a local improvement, by which we mean an intervention, an idea, a process, a great result essentially, and actively, in a very proactive and deliberate way, disseminating it across a system. That is, making it happen at a much larger scale than the place where it originally took place. And so everything that I'm going to be talking about relates to a good practice that we know of, a high-impact, evidence-based practice, a good idea, a new process of care delivery that has actually produced a better result. And then taking it from the scale at which it was originally developed and moving it to a much larger geographic area covering a larger number of facilities, a larger number of patients. And that's essentially what we mean by scale-up or spread. Now, there are some things that we know about scale-up and spread, and those relate to some of the key issues about the uptake of such good interventions, things that have produced better results. And I'm going to share these with you just to put things in perspective. There is a notion that if it's better, why doesn't it happen? And in reality, it doesn't happen. And we see a lot of places where great practices, great results are just not being taken up. And there are probably good reasons for that. I'm going to share with you some results that are a few years old, but they're still just as valid today as they were when they came out. And if we look at others, we're going to find a similar phenomenon across the board. These come from the Agency for Health Research and Quality, and essentially what we're looking at is physician compliance. This was work done in the US with evidence-based interventions such as counseling patients against smoking, only being done for less than a quarter of the patients. Mammography screening in a similar way. A blood thinner when somebody has a particular heart condition that can make it where the rhythm of the heart is not regular. being given for less than half the patients who need them. Using drugs that, particular drugs for heart failure, being done for just over a third of the patients who need them. If we look at evidence-based practices and we looked at interventions and we look at different types of things that are known to be good, that are known to work, we do not necessarily find that they're being taken up in the way that they should be. Some of the patients get some of the care some of the time, but not necessarily all the patients all of the time. One of the other very interesting ones was a piece of analysis that was done again by the Agency for Health Research and Quality, which looked at the pathway from original research all the way through to implementation. And you can see a very complicated, intricate sort of diagram showing what happens to things. Essentially, what the conclusion is that it takes a very large number of years, something like 17 years, to turn about 14% of original research into the benefit of patient care. Now, these results really tell us what is happening in the field, to show us that it is not as straightforward as we would like it to be. So in many ways, we in the area of improvement are looking at, well, we can make great improvements, and we see that there are great results, there are islands of excellence everywhere, but we were seeing much less of the real uptake, the large-scale spread of these great things to much larger areas than they were originally developed in. With that, we started to look at, well, how can we actively work on making sure that the things that we know to work, the things that have proven themselves, are being spread to as large a degree as possible. Some of the knowledge that we have on this comes from the work of Everett Rogers. Everett Rogers wrote a terrific book. If you haven't read it, I highly recommend it. It's called The Diffusion of Innovations. And I'm just going to refer to a couple of things that Everett Rogers talked about, which are pertinent to our understanding of spread and scale up today. The first thing is what he calls attributes of an innovation. That is, if we have something new, something that, a great practice, a better result, what are the things that make it more or less taken up by others? And in looking at that, he described 5 different sort of characteristics of any innovation that would enhance or otherwise its uptake. The first one is relative advantage. Whatever it is we're talking about, if it is not better than the existing, then the likelihood of it being taken up is not very high. Why would somebody opt for a lesser result? So being able to show that whatever it is we're talking about, whatever it is we want to actively disseminate, is actually better than what exists today is key to a successful spread. Compatibility with existing systems, with existing belief structures, with existing habits, etc. The more compatible it is, the more likely it is to be taken up in the social context that we're trying to spread it in. Of course, the less compatible it is, the less likely, it becomes more difficult for people to sort of accept that, to find it something that they would necessarily want to take up. Complexity. Complexity is another issue that would make it more difficult for an innovation, for something that is good to be taken up by others. The more complicated it is, the less likely it is to be taken up. That's inevitable. And so in many ways, as we're looking at direct spread, as we're looking at taking things to scale, we do want to make them as simple as possible so that their uptake is enhanced through simplicity. Trialability. People love to to play with things. You know, there's this whole notion of resistance to change, and I heard about it a lot before in the early days, and then it really dawned on us that people aren't actually resistant to change. People are actually very open to change, and if you look at yourselves, you'll find that you've changed considerably over the last few years, and you've taken up new things and new ways of doing things, etc. People are more resistant to being changed. So in taking up anything new, what you actually do is you test it out and you adapt it, you try it, you make it work for yourselves. Even if you look at your cell phones, everybody has their own, you know, applications and things set up in their own way. If you look at the way you operate with anything, the ability to try something out, see it for yourself, adapt it for yourself is key to uptake. The less able you are to try it out and see what it's like for you and adapt it for yourself, the less likely you are to accept it. And that is another key thing in the spread of innovations. Observability, and with that we mean the ability to see that the new system is better than the old, and to be able to see the results of what we are producing. Again, the more visible it is for us, the more likely it is to be taken up by the social system in which we are trying to spread it. The other issue that I'd like to refer to from the work of Everett Rogers refers to categories of adopters. That is, different people and where they lie on a spectrum of adoption. The curve that you see in front of you is it's a natural distribution curve that basically has numbers of people on the y-axis and then time on the x-axis. The further away from the 0 point, the more time it takes. And it basically shows the distribution of people with respect to the adoption of an innovation. And it shows categories that of people that Everett Rogers labeled that within that. He categorizes most people, sort of if you look at the middle of it, as an early majority or a late majority. And then a little bit earlier than the early majority comes a group that he called the early adopters, and just before that the innovators. And then at the very far end of the graph are a group of people that he calls laggards. Now this distribution is important because, and I remember in my early days in working in the field of public health, we always talked about the importance of consensus and getting everybody on board before we even start. With time and working on improvement, I started to understand that this is not necessarily the best way to go, and sometimes waiting for consensus doesn't get us very far. In fact, just delays us unnecessarily. Everett Rogers in Diffusion of Innovations describes the group of what he calls early adopters. These are people who are open to ideas but are also highly interlinked with the systems in which they exist. And they are in many ways opinion leaders in those systems as being key to the adoption process. And when one goes to a social context, he finds that there are some people who would be classified as innovators, a small minority at the top end who are basically the people who come up with the new ideas, etc. But they tend to be connected more with the outside. They tend to be less connected with the systems in which, or the social systems in which they operate. They're great for coming up with ideas. They're not necessarily people that will lead the way for the majority of others, whereas early adopters who are much more interlinked with their systems are a key to adoption. And getting some of them on board then brings along a lot of the early majority who look to them for guidance and for leadership. And once you have that sort of majority coming in, then others start to follow, the late majority comes on board, etc. there'll always be people who don't come on board, and waiting for them just delays things. Even when so much has happened, there'll still be some people at the tail end who don't come on board. So it's very important for us, as we're trying to actively disseminate a new intervention across the system, to identify who are the opinion leaders in that system, who are the people who can bring along the rest, and working with early adopters is key to successful spread of innovations. Now, having said that, I also want to talk about some of the key insights that we've sort of formulated as a result of this. The first one is that the attributes of the innovation actually hold true. You know, we find that by and large making sure that we have addressed attributes in a way that makes them more likely to be taken up is key to successful spread. The second thing are the categories of adopters. Now, Everett Rogers describes them in a very static way. It's a point-in-time distribution. For a particular innovation at a certain point in time, that's what the distribution looks like. However, we've also learned with time that the same person can lie on one end of the spectrum with regards to one type of innovation, and another end of the spectrum with regards to another type of innovation. I use myself as an example, as somebody who travels a lot. For me, global roaming cellular connectivity is key. So I'm sort of like on the left-hand side of that graph. I'm an early adopter, if not even trying to come up with new ways of connecting myself. When it came to something like the iPod for music, I'm way back. I never had one. It's been years, and although I think the music that comes out of it is beautiful, but it's not something that I want. So the same person with regards to different types of innovations can be in different places. The other thing is the same person with respect to the same innovation can change over time. I use my father as the example. It just so happened I was talking about spread one time, and he was visiting me. For years, when I was in my home country in Palestine, I tried to get him to use the computer, and he reads the BMJ religiously. We'll wait a month to get it through the mail, but wouldn't go online to look at it. And then he just wasn't interested. That's not something he liked. When I left, and he realized that all children are away, but all of us travel, and therefore our means of connectivity was email. The next thing I knew was that he was on email, and one time he was visiting me here in the U.S., and my internet was down. The cable company, something went wrong with them, and he was complaining that I don't have internet in the U.S. So the same person, with regard to the same type of innovation, can change over time depending on their needs. The last thing is that Everett Rogers, and I hope you do read his book, really talks about the spread of an idea. So that is the passive spread of an idea from an individual to another, unless there's a change agent, and he describes roles of change agents, which make it a little bit more active. Whereas in most of the work that we're doing, we're not talking about the spread of an idea from an individual to another. We're mostly talking about the directed change in systems. So that's a much more different requirement. And we find that the thinking he has in diffusion of innovations is very relevant to the directed change in systems, but it's not sufficient, and we have to think about some of the other things in relation to that. With that, we also try to think about frameworks that would help us in the spread effort, and I'm going to share with you this framework for spread, which is the framework that we use, developed by the Institute for Healthcare Improvement. And it looks at, in brief, there's a white paper on the IHI website. I hope you download it and read it. It's a very good one. It looks at the better ideas, the better interventions, the high impact interventions that we have, and then at the far end it looks at the social system in which we want to spread them. Now you can see the social system consists of multiple people, communities who have different types of actors within them, some of whom are the thought leaders, some of whom are messengers, and there are rules that govern these social systems. So being very cognizant of the way in which the communications happen within that social system is very important. In order to get better ideas across to the social system, there's a whole setup involved, which looks at who are the people that we are trying to target in that social system, what are the categories of adopters within them, who has already accomplished things that we would like to make sure are being highlighted, because it really makes a difference if somebody has already made some progress in the area that we're trying to spread. Looking at the partners that we would team up with to do that in order to get the better ideas across to the social system. To be able to see what we're doing, we need to have feedback loops. We need to be measuring progress and seeing that we're able to do that. So key is how will we know? And in relation to that, I think it's important that we not only measure what we're doing, but also learn from what we're doing, and therefore managing the knowledge related to that is key. And today I think there's been so much progress in the area of managing knowledge that is in itself worthy of a conversation. But certainly the type of knowledge that I would emphasize gathering and making sure we're creating is the knowledge that is in the thinking of the people who actually do the work themselves, the tacit type of knowledge that only comes through human interaction, through conversation, and is very valuable to others who are trying to do the same thing. All of this does not happen without leadership. Scale up on top of it and managing all the aspects of the spread. In developing a spread strategy, there are three key questions that we ask. The first thing is, what is it that we want to spread? We need to be explicit about what is the great spread-worthy result that we're going to spread, what is the innovation, the intervention, the best practice that produces it, and being very explicit about that upfront. The second is, to whom do we want to spread it? How many, who are the members of the social system? How many facilities? How many patients? And putting a timeline is really key, because the timeline forces us to work backwards and to develop plans that are much more aggressive. We want to spread as fast as possible. So the putting boundaries on time is key. And then looking at the spread strategy itself. How are we going to do that? And there are multiple ways to spread. There's no right or wrong way, but there are some better ways depending on the situation at hand. And that's the next thing I want to talk about, which is how do we spread? Now, as I said, there's no one way to do it, and there are multiple ways. I want to first of all talk about natural diffusion. That's what Everett Rogers describes in his book, Diffusion of Innovations, and the uptake by individuals in a social system. I mean, that's one way in which things have spread and in which best practices have been adopted. Another important way is extension agents. This is something that that was used heavily in the agricultural industry in the U.S. Years ago with people traveling from site to site and sharing experiences and best practices with others as they're doing that. Today in improvement, we actually use that without so much acknowledgement of it. Through our coaches, the people who go and visit the facilities, different facilities, and exchange experiences between them as they're doing that, share with them what they know, but also teach them what others are discovering and learning. A very important way in which we are using that as a spread method all the time. I think there's a lot to learn from emergency mobilization. When something happens and a catastrophic event happens, and how places like the International Committee of the Red Cross are able to, and others of course, are able to just mobilize so much support. I think you know, for emergency mobilization there has to be something key, something that people feel strongly about, where we can actually get a lot of support. But there's a lot to be learned from that, because they do it very quickly, they do it at scale, and they're able to leverage a lot of support for it. All of us are these days in the world of improvement using collaborative improvement methods, and certainly collaborative improvement is a means of spread. I mean, you have 50 sites, 100 sites, you're already spreading to 50 or 100 in that collaborative. So that's an important one, and I want to keep that in mind as well. Virtual collaboratives, these are collaboratives that take place over the internet, just like this webinar is happening now. Again, one has to be cognizant of what can be done through a virtual collaborative versus when you need physical interaction. I think the interventions that are simpler, that are possible to transfer through virtual communications would be you know, open to that type of spread. Of course, those that require much more systematic changes and need a lot more collaboration to make happen probably would not be the type of thing to put through a virtual collaborative spread mechanism. Campaign spread, we've seen campaigns here in the US. ISQua led the 100,000 Lives, the Million Lives campaigns. We've seen them in several European countries. Very effective means of spread. Again, the beauty of campaigns that you can reach all at once. That's a very important part of it. But then one has to also be aware of what are the campaignable types of interventions. Not every type of intervention is something you can spread through a campaign. Simpler interventions, just like with virtual collaboratives, are much easier to spread through that. Wave sequence, which I'll come to in a little bit, is a specific type of spread that we developed 13 years ago when we couldn't reach all at once, when we had to take a phased approach, and I'll talk about that in a minute. And then more often than not, what we see are hybrid models. That is, they combine more than one element. So for example, in a lot of our work we have a collaborative, but we also have extension agents built into the collaborative model. You'll see sometimes a virtual collaborative where the first meeting is in person and the rest of them are virtual. Different types of models that are a combination of different ideas and different other types of work, and these are usually very successful because whomever thought about them, you know, sort of thought through. I said, well, probably need to have some of this, really building on their knowledge of the system, the social context, the interventions they want to spread, and developing things very much adapted to that setting. I want to go to wave sequence spread. Now this is, let me tell a story here. This developed basically in 2000, and we're working with our colleagues in the Russian Federation. We had embarked on a couple of years prior to that of very successful demonstration projects on how improvement methods can be adapted to the organizational culture in the country with terrific results. I mean, one example I'm going to use here is we worked on improving care for neonates with hyaline membrane disease. Case fatality came down within a year or so by 64%. Through reorganizing the care system. This was done at the level of 5 facilities, 5 hospitals that basically represented the 3 different levels of neonatal care and the different geographic distributions in a place called Tver Oblast. With that sort of success, the idea was, well, can we spread this? And immediately thought, well, why don't we go to the whole oblast? That's the geographic area in which that was spread. And we ran into financial constraints trying to do that. The interesting thing was the constraints that we had were actually created the environment that led us to thinking about this type of spread. And I'll go through the spread to sort of talk about how that happened. So imagine if this is this could be like Tver Oblast, this could be a country, this could be a region which has some sort of central location, a capital city, for example, has some geographic distribution. These could be districts or provinces, or they could be regions within the same. For example, in oblast, these would be the rayoni, each one of which has also a large city and a number of facilities. And we're deliberate about making the larger facilities be closer to the center and the smaller ones be further away. In most of the systems that we're dealing with, these are nested systems. That is, there's a hierarchy, there's a referral mechanism, upward and downward, etc., that sort of works between these facilities. And then each one of them, if you look at the number of facilities, they'll basically cover a certain population that lives within the vicinity of these facilities. Now, we call this a slice of the system. That is, that the number of facilities that are interlinked that cater for a certain population. And as you can see here, I'm showing illustratively a number of slices of the system. So if we wanted to work in a place, and again, I want to repeat that this would be only applicable if we cannot reach all at once. If we can get to all of them at once, there's no reason to delay anything. We should just do all at once. So if we can put them all in one collaborative, that's what we should do. If we cannot, because it's too big, it's not doable, then what we would do is, if we want to tackle the whole area that's shown on this illustrative diagram, is we would take a slice of the system. We would take one slice in each of the regions, because each of these regions has an administration of its own, for example, although they're all interlinked. But there's, whomever heads up that petal on the flower is responsible for that whole petal. And so taking a slice in their area would be one way to start. And then we would develop our initial demonstration in those green slices, as you can see. Towards the end, we would identify champions from these slices, and that's exactly what we did in the example in Russia, where this was developed. We identified people who got very excited, very competent in doing this. They had achieved great results in their sites. And then we identified the remainder of the system that we want to spread to. Those are the brown slices shown in the diagram. And then we used the champions from the original demonstration sites as spread agents to go to the rest of the system in their geographic area. Now, by doing that, we saw a new phenomenon. And that new phenomenon was about how much ease there was in moving this to scale, multiple. So, for example, in the RDS, neonatal respiratory distress syndrome, hyaline membrane disease example, we went from 5 sites to all 42 that cover the whole of Tver Oblast. In parallel, we were working in Tula Oblast, for example. We went from 5 facilities to 442 facilities that catered for patients with hypertension, using that same type of thinking. Now, this model has worked beautifully there. Very soon, in fact, as we were sort of getting results in Russia, colleagues started to use it in South Africa, later in several of the countries that the Quality Assurance Project and later the Healthcare Improvement Project at URC started to use this. We also, this was used by HI again, not just in South Africa, but also in the design of the Ghana project. Also, we used it for a large-scale spread in Kaiser Permanente, taking innovations that have worked in one hospital and spreading them to others, and also using them as an initial point in one hospital and spreading to the remainder of the hospital. And also in the design of the NHS Scotland safety program, which is now one of the most successful safety programs that we know of. That type of start somewhere and you then use the people from there to spread to other places in that region. I want to talk about a few of the principles of scale-up, and I want to start with the fact that in order to scale up, it's best to start with the end in mind. That is, what is the full scale we want to reach to? And there's two reasons for that. The first one is, if we start with the end in mind, then we design, our designs will be much more conducive to spread at a large scale, and then we're able to take them to we choose the geographic locations that then become much more conducive to the remainder, to taking them to the remainder of the system. Second is, if you can reach it all at once, you should. I don't think we should delay anything, and we should just be aware of, what method, what approach is going to allow us to go as fast as possible and achieve as best results as possible. If we cannot go to all at once, then we look for nested systems, we test prototypes and expand, and as a rule of thumb, multiples of 5 to 10 are usually a good way to go. We found that beyond 10, when you're using champions, it becomes a little bit more difficult. In the Tula example that I mentioned, going from 5 to 442, there was actually another sequencing that had to happen just because the numbers were too large. Think about some factors as we go to scale. The first one is arithmetic scale-up. So if we're talking about, for example, scaling up treatment, that means, and that involves tablets, well, if we're going to 10 times the scale, then we need 10 times as many tablets, so just something like that. At the same time, if we're talking about weighing patients, well, the same scale that caters for these can also cater for 10 times as many patients, probably, and just keeping in mind what things need to be scaled up arithmetically and which ones don't. Information systems are key. Again, the type of measurement we can have when we are working at small scale is very different. We can collect the data. It's a limited number of sites. When you go to scale, it really has to be built into the information system of that country, of that system, and so really considering that carefully as we go to scale. Communication needs, again, the learning and the ability to share across is key to successful spread. To the extent possible, that's something that we need to be designing upfront. And then oversight needs. Again, we can conduct a pilot with relative ease without a lot of involvement. When it comes to scale up, it is a leadership function and requires that type of oversight. Some of the lessons that we learned as we did that, as we have scaled up and done this over and over, the first thing is results are key drivers. They're, as I started by saying, we have to have spread-worthy results. If they're not spread-worthy, why would people even accept them? And when people see results, and if you can show results early on as you're doing this, people will get more engaged, more excited, and are much more likely to take this seriously and work with them. As we do this, we really have to be thinking about how we enable people to make changes in their work. Improvement is about change, and so without systems thinking, it's very difficult to do that. Equipping people with a change model like the Plan, Do, Study, Act cycle, which allows people to proactively and deliberately design and test and implement different changes. Site visits are key to if we can build in that sort of extension agent type arrangement, and we do that all the time with our spread efforts. Leadership support, critical. One of the key things is, if this is what's important to the system, what we should do is have it on the agenda of the regular leadership. That is, whomever is running the system, that would be an item on their agenda. It can't happen as a side project with somebody else, being delegated to somebody else. It has to be led by the people who are responsible for that system, and a lot of role modeling. I think extension agents or agents of change who work with different systems play a key role in how they behave and how they look at this in order to energize people in this direction. Giving the once we've made improvements, then you need the written documentation, the regulatory support that makes these things stick and makes them part of the way the system operates going forward. One of the key things to keep in mind is that people who are working under constraints can be very creative. We've seen over and over that, and as I said in the example from Russia, the wave sequence spread, it only came about because we were under constraints. If we had had enough money to be able to just bring in a bunch of people from outside and just work as we had done in the pilot, we probably would have done. I don't think that we would have had to think carefully about how we use the people from the demonstration sites to spread to the other to the rest of the system. So constraints really can be the reason why we get creative and we develop new models. Scale-up efforts require meticulous attention to detail. I think it's MSF that says amateurs discuss strategy, professionals discuss logistics. There is so much to be said about attention to detail, about the whole, how we set it up so that it can work, and going through all of the detail. There has to be a plan, but attention to detail is key to success in these plans. Champions who develop the prototypes are critical for scale-up in wave sequence, as I said before, and this has become a mainstay method in our work and several other groups' work in spread. And using the champions from the original prototype or demonstration sites is key. And leadership from within the system. Again, as a foreign agent, one can, as a change agent, one can sort of affect some change at the local level. Going to scale is really a leadership function. And that sort of summarizes some of the key things that we have learned as we've done that. The last point I want to make is I still call it new learning because we haven't sort of, it hasn't been disseminated as much, but I want to go back to the Russia example. When we were working in Russia, one of the things that we expected is that, or at least we agreed that we're going to go to scale. We realized that we're going to use the champions from the original site to spread, and we sort of had this assumption that if we can get half as good results in the spread effort as we had in the original demonstrations, we're going to be thrilled. If we can even get half as good, because there's always this notion that when you go to scale, things are not quite as controlled. Things actually don't happen in exactly the way that you want them to, and there's a serious drop in voltage. As we embarked on the spread effort, we were very surprised to see that things were moving smoothly. We got less, we had fewer problems, and we're looking at initial data which isn't suggesting that we're encountering the problems we had anticipated to encounter. So I remember looking at that and thinking something must be wrong, and my colleagues, we decided to make a few visits. We went and visited sites, and to my great surprise, it was like that. And then the results started to come in, and what we found was actually we're getting much better results than we had anticipated. And actually they exceeded. We had 3 spread efforts simultaneously based on the 3 demonstration projects we had conducted. All 3 of them in the spread phase were doing better than the original demonstrations. We're getting far deeper results, easier, quicker spread. And I reflected on that at the time, and I said, well, it must be because, one, we've worked them out. It must be because there's what Everett Rogers calls the homophily factor. That is, instead of somebody from outside bringing in foreign experiences, you've got people from within the system sharing with peers what they have done in their own sites, which are very similar sites. So all of that must be taking place. And there's a lot of truth to that. Years later, I was looking at some other results, and fortunately, on the Quality Assurance Project and the HCI project, one of the things that was happening is that they were able to stratify the old sites and the new sites, the original demonstration sites and the spread sites. So I want to share that with you and show you this. So this result comes from Uganda. You can see it's from 2005, 2008. The blue line are original demonstration sites. The pink line are spread sites. You can see essentially that the rate of spread just was far quicker in the spread sites. This one is Niger. Again, the pink line are the new sites. You can see the rate of spread much faster. This is Guatemala. Again, the purple line are spread sites. You can see, taking off at a much faster speed. This is Rwanda, not only taking off at a faster speed, but also exceeding the results in the original phase. This is Ecuador. And graph after graph we were looking at was showing the same phenomenon, which really explained to me what we were seeing. Essentially, in going to scale, if we set it up right, and we have great results in the first place, and we use the people who developed those demonstrations to be the spread agents to peers who work in similar facilities, the likelihood of success is far greater, and the rate of spread and uptake is far quicker than the original sites. Now, this is not exactly the original thinking we had something like 15 years ago, where we thought we would see a drop in voltage, where we thought if we can get only half as good results as we in the spread as we had in our original demonstration. Not true. Today and for years now, I've been saying, well, if it took us a year to develop the demonstration, or 2 years, I would need just as much time. I can go to 5 to 10 times the scale, and it would probably cost just as much. And this has been a rule of thumb I've been using. It's worked beautifully up till now. I'm going to stop here. I think we have a few minutes left. I'll hand back over to Peter, and I'm happy to take any questions.
Rashad, thank you very much. That was a clear explanation of scale up and spread, and a very elegant blend of theory and personal practical experience. And the questions have been arriving by the minute, and I have a number here, so I'll present them to you. I may not be able to cover all of them with you, but let me start. The concept of innovation can be tricky. In this context, is innovation something new to a particular environment, or something new to the whole scientific world?
That's a very good point. I think what we're talking about here is more like innovation to a particular social context, not necessarily an innovation is something new to the context we're trying to spread it in. That's probably what I'm talking about, more than an innovation worldwide and to the global community.
Thank you. Some ways to spread are more appropriate than others. Is this based on what is at stake? For example, ideas versus processes?
Sure, it is based on that, and I would say the following, that first of all, the type of change that we're trying to scale up is key. If it's simple, then it's more amenable towards simpler methods of spread. If it's more complicated and requires a lot of systematic change, then I would use other methods that are more conducive to that type of change. The other thing is, can we go to all at once or not? If we can go to all at once, that would be the preferred method rather than slowing down the process. If we can't go to all at once, then we have other methods that allow us to go faster than an additive, that is 1 by 1 by 1 or 10 by 10 by 10, by using something like wave sequence, which allows us to go from 5 to 25, from 25 to 125, taking sort of 5 scales of 5 to 10 each time, as opposed to one by one.
And we have another question. Some innovations are taken up very quickly and very easily, such as a simple one, such as a surgical checklist. But there are others that might be just as simple that seem to take years and seem to face resistance. Do you have an explanation for that?
Well, I wish that the surgical checklist would be easy to uptake. It is definitely one of the best interventions that we can scale up, and I just hope that it does get taken up that quickly. I'm not sure that that is the case. I think at least from what we're seeing, there isn't as much take-up as we would like to see. I think it should be done in every single hospital for every single patient who undergoes an operation. I'm not sure we are there yet, and it's been a few years since it's come out. I certainly hope that will be the case. It's such an important intervention. Why are some others? I think if we go back to the attributes of the innovation, that would shed a lot of light on why some of them get taken up easier than others. But also there's a natural sequence to this, as I showed earlier. I mean, we have a problem with uptake. It's not, at the beginning of the session I was talking about the problems we have with uptake. They're not unusual. I hope we can, through a lot of concerted effort, make sure that things like this surgical checklist are really taken up for every patient who undergoes surgery.
Thank you, Rashad. Another question we have is that how do we determine that an intervention is successful before we talk about scale-up?
Oh, results. I think if we can show that it has significantly better results than the existing ways of doing things, then that's probably a scale-worthy intervention. It's worth doing. Yes.
So
there's no substitute to results.
So measure everything.
Well, I would say, I mean, depending on the intervention, what is the outcome we're seeking from that intervention? I'm not into heavy measurement. I think we should measure only the smallest amount of data that would tell us that something is better, but certainly if we can't show that it's actually better than the existing, then I would question why are we spreading it. And I do pose that question actually in our work. I would also say, what is the spread-worthy result that we are trying to scale up to this whole country? Is it better than what exists? And if not, then I question why are we wasting people's time, effort, money? It's a questionable thing to do.
Moving on to the next question. What happens if one slice of a wave sequence spreads but does not perform as intended?
Can you repeat the question? I don't understand it.
The question is, what happens if one slice of a wave sequence spread does not perform as intended?
That's an interesting question. One of the things here is, and I probably didn't say that. That's why the question came up. So in the original slices that we had, we would actually work with the slices together. So they're not working as individual slices on their own. They're actually meeting up, and there's collaborative learning and sharing across. And as you know, when you do that sort of thing, what happens is they reinforce each other. It's just like in a collaborative setting, not everybody has to invent everything. All you need is one site to discover something, to invent one thing, and everybody else takes it up. So even a slower, and that's the beauty of collaborative improvement, shared learning, is that when all you need is one place to make it happen, and everybody else comes on board, and the likelihood of uptake is very high. With the exception of some other factor playing into this, for the most part, peer-to-peer learning is very powerful, and you know, if some, I don't know that the whole slice is struggling, that would be a peculiar situation. But if a site is struggling, I think there's assistance that can happen in terms of site visits and exchange visits to other sites, etc. And people have done well sort of going to see them or vice versa. That moves things along.
I have a question. Resources are a major bottleneck for spread. Goodwill and hard work alone are not enough for scaling up in limited resource settings. What are some solutions and lessons learned?
That's a great question. Thank you. The first thing is that whenever we're talking about a system that has not been improved, we're talking about a system that probably has a lot of waste, a lot of unnecessary things taking place. And whenever we streamline processes, we not only get better results, but we also reduce cost, we reduce waste in that system. So that's a rule of thumb. Of course, there are some places where you actually have to sort of invest you know, in some things that didn't exist before. But inevitably, whenever we're not doing the right thing, we're probably doing a bunch of wrong things anyway. So that's sort of one thing to consider. The other thing is there is an initial investment in terms of making an improvement and taking that improvement to scale, and that investment manifests itself in energy, time, work that has to be done, meetings that need to be convened, etc., which have a cost to them. However, the more important part of it is that once we've done all of this, then the chances are we're not only getting better results, but we're also probably saving on a lot of the waste that has been eliminated from that system. I would say, you know, it's well worth the investment, initial investment for the long-term, not only improvement in results, but savings on waste that come out of that as well.
Question about the role of clinicians. You mentioned in the Rogers model of adopters that the early adopted are connected with outside groups, yet we constantly hear the cry that we, the clinicians, are different. How do we get clinicians to look beyond the first fallacy and broaden their vision?
Great question. So it's actually the innovators he describes, a very sort of top-end group that he describes as innovators that are not necessarily well linked with their systems. But then he describes the early adopters as the opinion leaders and the thought leaders in these that are intricately intertwined with their systems. Clinicians, it's very interesting because I think we see sometimes that there are some efforts where clinicians aren't involved. I think it depends on what we're trying to do. If we're focusing on administrative processes, the chances are we're not going to get a lot of physician involvement. When we look at outcomes of care, if we're trying to improve patient outcomes, which are essentially a result of a lot of clinical and non-clinical processes coming together, the likelihood that physicians don't get involved is much less. And most of the work that we do, we will gear it towards what are the better patient outcomes we can produce. And within that, we find that physicians normally get excited and become champions for improvement. So I would, at the get-go, just say, well, if we're interested in, if our work is healthcare, let's look at patient outcomes and try and improve outcomes of care. And by virtue of setting it up that way, the likelihood of bringing physicians on board is much higher. I think approaching improvement as a multidisciplinary function, something that requires multiple inputs, not just the clinical processes, in order to produce the outcomes. At the end of the day, especially if we're dealing with chronic conditions, we're really looking at things that happen at home, by the patient, by their family, all the support processes, all, you know, if it's diabetes, the nutritionist's role, the other functions that really come to play here to produce the outcomes that we need. Then the likelihood of physicians collaborating with other professionals in the healthcare processes that yield those outcomes is going to be much higher. I would really urge looking at it that way in order to get the people, the right people on board.
Thank you, Rashad. Our hour is up. I have one question that draws in the question of different cultures and the application of this to different cultures. There are many questions that I haven't been able to ask, and I wonder, Rashad, would you be prepared to answer these if I invited the questioners to send them to me by email, and then I asked you to answer those questions and then provided that information to the questioners?
With pleasure, certainly. Please email them to me. I'd be happy to respond to them by email.
Right, thank you. So if you've asked a question today and we haven't had time to fit it in, you could either email it to me at ISQua or to Dr. Massoud, and we'll get an answer to your question for you. So please follow that up, because we'd like all those that have taken the trouble to ask questions to have an answer to their questions. Rashad, the final question that I'll put to you is this. The wave sequence model is very helpful in more or less homogeneous systems. What happens in more complex cultural areas? Could you discuss the inputs needed, costs of creating and supporting local champions to make systems changes?
Let me see if I understand that question. If the system is a nested system, then it would work. That's what you mean by that, or something else?
In systems that, I think the questioner is suggesting that the wave sequence model is easily adaptable to homogeneous systems, but in more complex cultural systems where they're not homogeneous, how do you need to vary that system to make it work?
Sure. I don't think we've used it in non-nested systems, that is, in systems that don't have natural linkages, because it's very difficult. Let's say we have, as you're describing it, non-homogeneous. We have an area that doesn't have a single administration, and we're using people from one system to go to another system. That becomes much more difficult. So I don't know that we've used it that way, and I think having a nested system, or if it's not a nested system, at least having agreement that they would function as if they're a nested system would be important for its application. Does that answer the question, Peter?
If it doesn't answer the question, then I invite the questioner to put it again to you or to me, and we'll get an answer one way or the other. Thank you, Rashad.
You're welcome.
Dr. Massoud, thank you very much for your time today. It's been a fascinating webinar. We've had a very large number of people participating, and we've had many more questions than we could answer within the hour, and we've run a little over time. So again, I'd invite the questioners whose questions weren't answered to send them to me, pcarter@isqua.org, and I will talk to Rashad about answers to those questions. And once again, Rashad, thank you very much, and we hope that, I know that you are joining us in Edinburgh at our conference starting next week, and I do hope that many of the people that are participating in this webinar will be there too. Thank you very much.
Wonderful. Thank you very much. Bye-bye.